Good afternoon, everybody. It's another beautiful day in Sonoma County. I keep saying that. It is Thursday afternoon, June 3. We're back with some more information today about COVID. And I have Gary here with me, and we're going to dive right into some of the recent epidemiology. So, Gary.
So worldwide, I think things are still struggling in different pockets. And I just want to show a couple of brief epidemiology slides. India is really struggling. That's the first slide I'll show you. India is struggling, and it looks like the case rate's going down in Italy, but the University of Washington thinks that they're underrepresenting their cases or underreporting just because their infrastructure is imploding. They're struggling just to keep up with cases, and they're struggling with oxygen, they're struggling with beds, they're struggling with crematoriums. And so India may not be reporting its cases in a timely fashion just because of the crisis there. The next slide shows the death rate in India. India still has over 3,000 people dying a day. They have about 131 reported cases a day. And the University of Washington thinks that by a factor of 2 to 5, that's being underrepresented. So they may have twice as much or 5 times as many cases and deaths as being reported. So we'll hear more from India later. The third slide I want to show you is Malaysia. Malaysia is also struggling right now with an enormous peak that's above their previous peak. And there are other hotspots in the world. Iran, 9,000 cases a day. France and Russia are struggling with more than 8,000 cases a day. Indonesia and Nepal, more than 5,000 cases a day. The Philippines, more than 7,000 cases a day. Even Japan, which has a very low vaccination rate, is still struggling with 3,000 cases a day, and they're trying to get ready for the Olympics. So a lot of stuff going on worldwide, but I think the United States is positioned a little bit better. I'll show you some local data. This comes from Sonoma County. These are new cases per 100,000 population, and you can see our numbers are low, and there are lines here showing the tiers, but to the far right, there's been a little uptick of cases on this graph. And just yesterday, we had 57 new cases in Sonoma County, which is a real significant number. Next slide. This comes from the Public Health Department, and this is a 7-day rolling. So this is 7-day average of how many new cases per 100,000 population. In the middle line there is a California number. And as you can see, Sonoma County is the green line, and the green line is ticked up a little bit. We've actually gone higher than the 7-day rolling cases for the state. That's been mainly in 20 and 30-year-olds. So younger people are getting infected in Sonoma County more, which means they're not coming to the hospital because they're doing well with their illness, but they are testing positive. That's important, and we have to put that in perspective. June 15th, Governor Newsom's going to remove the tiers, and so it's going to be business as usual for the business community and churches and restaurants. But in the healthcare industry, we're still going to do the same stuff. We're still going to be wearing masks, social distancing, and trying to take care of patients who are PUIs. But I think this shows us that if we're ticking up now in a younger cohort, that may get worse when the tiers go away. Mm-hmm. So the fact that our county is well situated with vaccine is going to help us in the next few weeks.
Okay. So a lot of hotspots across the world, and we know a lot of that is due to lack of infrastructure, high density, but I've also heard you say that, at least in the United States, we now call this a vaccine preventable disease.
Yeah, actually, I talked to the County Board of Supervisors a couple weeks ago, and that's what my statement was. When you have a vaccine that's 94, 95% effective, this is now a vaccine preventable disease. In fact, the 2 cases I'm seeing right now in the intensive care unit, and one of them may not survive, is someone who chose not to be vaccinated. And I think in the United States, where we have that resource available now, where we have a surplus of vaccine, unlike other countries dealing with poverty and infrastructure, I think in the US, this is now a vaccine preventable disease, and luckily our vaccination rates are high enough.
So let's talk about vaccine. It does really feel like we're out of sync with the rest of the world. It was maybe 6 weeks, 2 months ago. We had what we thought was a dire shortage of vaccines. We're closing the clinics. So well, now it's just the opposite. Our supply is outstripping our demand for vaccines. A couple of weeks ago, we closed our mass vaccination site. We're just using the 3rd floor of Airway right now. And likely in 2 weeks, we'll be shutting that down because the demand is just not there. It's no longer kind of a build it and they will come situation, because the reality is the easy work's been done. And now we're getting to the hard work, and that is trying to identify and educate those people who are hesitant or resistant. And I'm going to show you a slide that came out of the New York Times. It was a poll, 2,097 adults, nationwide poll, asking them about their attitudes of vaccinations. And you see that people were asked to choose one of 5 categories: either vaccinated, want to be ASAP, I'll wait and see, only if required, or definitely not. And you can see that, there's ethnic, this chart points out ethnic differences, points out political differences, and you can still see there's a lot of work to be done in all these arenas. And as you know, and these are differences that most of us are fully aware of. It's been in the lay press, it's talked about a lot. The next slide, however, puts on a new overlay, and that is education, as defined in this study, this poll, by college graduation. So we already know that education is highly correlated with, health, wealth, income, all those things. And now when you overlay it on the initial variables, you will see that every category drops down just to the variable of education. So there is a lot of work to be done out there, and this just shows you that there's not one approach that's going to tackle this. There's many, many variables that need to be approached. It's not simple, it's not straightforward, it's hard work. And I just want to point, and I feel like I'm speaking to the choir to some extent. I think most of you people are aware of that. But this is the hard work, and I would like to shout out and appreciate those people who are doing this hard work already. Those of you who volunteered at the pop-up clinics, and certainly like Brian Prostowski, your I'm In campaign, which is very focused on ethnic disparities. So keep up that good work, because we're going to have to do that to get the county where we really want it to be.
Gary, there's a big difference between vaccine resistant and vaccine hesitant.
Okay.
People who are vaccine hesitant are sort of on the cusp. They're kind of wondering, and I saw a study with a lot of mothers of young children are very nervous about getting vaccinated or their children vaccinated, but they're not resistant, they're just hesitant because they're worried about safety. And they just don't have all the information. I think a lot of the work that Brian's been doing with the Latino population and other ethnic groups is they just need more information, and they just need a little bit more conversation. So I think there is an opportunity where we can tip the scale to those who are vaccine hesitant, but we may or may not make trends with those that are vaccine resistant. Those are the anti-vaccine people.
Right. So Gary, I have a question for you. So here I am, I'm living in a county where we've essentially reached herd immunity. I'm vaccinated. We know that in the community of symptomatic individuals, symptoms that could correlate with COVID, 97 to 98% of them have a negative COVID test. So what does that mean for a practicing physician seeing patients? What kind of risk are they at?
That's a really good question, and I'd answer that 2 ways. First of all, about 98% of people coming in with symptoms concerned about COVID will have a negative test.
Okay.
So their positive predictive value for having COVID is very low. There's a subset of patients who are asymptomatic and they don't know they're infected and they can transmit it, and we think that's for a shorter period of time. But when someone comes into the office with symptoms that overlap with COVID, the risk of them having COVID is not as high as it was a few weeks or a few months ago, less than 2%. The other part is if you're vaccinated. If you're vaccinated, what does that mean? And just last week, the MMWR, the CDC published an MMWR on vaccine breakthrough infections. People who have been vaccinated in real time right now. So now we have this mix of variants. So from January to April, how many reported cases of breakthrough were shown with the Public Health Department? I'm going to show that slide right now. This is from the MMWR. The left is kind of busy, and so I'll just briefly go through this. And then I put in the box to the right some sort of extrapolated calculations. First of all, about 101 million people in the United States were vaccinated up to this point in the study. And so of about 101 million people, there were 10,000 breakthrough cases and 27% were asymptomatic. So of the 10,000 breakthrough cases out of 101 million people, that means that 73% were symptomatic. 10% were hospitalized, and 2%, or 160 patients in this cohort, actually didn't survive COVID illness. Now, if you think about that cohort, the average age of those that didn't survive was 82 years old. So that tells me we still need to protect the elderly. Because likely, if you think about a vaccine that's 95% effective, that's overall. The elderly might be a little bit more in the non-responder category. And if they're not responding to vaccine, they may not still survive an infection if they didn't mount an immune response. So that's what that data tells me, that the elderly are still vulnerable, even with a history of vaccination. We need to be careful about them with public health measures. Now, this study looked at variants. 56% of these breakthrough infections were the UK variant, and that kind of goes across what California is seeing and what the US is seeing with the variant distribution. So the B117 UK variant was not more dangerous, it was just more prevalent because it's more contagious. So I took those numbers and I put it in this box. If 101 million people were fully vaccinated, then the risk of a breakthrough infection in this cohort, 0.01016%. So that's the chance of having a breakthrough infection if you're vaccinated, fully vaccinated. The chance of being hospitalized, the risk is 0.0009%. The chance of dying from COVID after you've been vaccinated, 0.00015%. So vaccine is incredibly effective. In the US, 94-95% effectiveness with the mRNA, Pfizer, and Moderna vaccines. That's extraordinary, but these numbers represent actually more than 95%. These numbers really represent far above 99%. Now, let's say you kind of don't trust the numbers. Maybe this is underreported. So let's say by a factor of 10. Let's say there weren't 10,000 cases. Let's say there were 100,000 cases. So your risk of being hospitalized with COVID is 0.01%. And your risk of dying is 0.001%. It's still, the numbers are incredibly low. So this is very reassuring, just published last week with the variants in the US, that vaccination is really keeps you in a very safe place. So to go back to your question, I'm a provider. I'm seeing someone in my office with COVID-like symptoms. Could be rhinovirus, could be seasonal allergies, could be enterovirus in the fall, could be the flu. The chance of being COVID right now, less than 2%, and your risk if it is COVID is extraordinarily low if you're vaccinated. We're still going to take precautions. Everyone's going to be wearing masks, face shields with POI patients, social distancing. That's going to continue even when the governor lifts the tier restrictions. So healthcare arenas are going to be part of that. But I think the risk is really low. I'm going to show you another slide. Now, is there science behind this cohort slide? Is there anything to support this? On the next slide, these are two brief studies. One of them is if you have natural infection, you have long-lasting cell-based immunity. In the lower left, in a preprint, vaccination gives you natural immunity for more than 12 months.
Okay.
So the science supports what this cohort showed in the United States. I think, Gary, if you're not vaccinated, COVID-19 is more contagious and more dangerous than the flu. Once you're vaccinated, COVID-19 is not as dangerous as the flu. The flu is more dangerous. In fact, if I ride my bike to work, the risk of death from riding my bike to work is 10 times higher, 100 times higher than the risk of taking care of someone with COVID if I'm vaccinated. So it's very reassuring, but I still think we need to be careful of the immunosuppressed, patients on Rituxan, patients on methotrexate, patients on other immune modulating agents, and the elderly. We still need to keep an eye on those in our patient populations.
Of course, this snapshot has to do with the current setup of variants that we're seeing. That could change. There are variants around the world that might migrate here. How might that impact us, or how does that change what we do?
So Sonoma County's been tracking that. And the last slide I'm going to show is just a slide showing the variants that we've seen in Sonoma County. What we've seen are the California variants. And in Sonoma County, we've seen a little bit of B117, the UK variant, because that's been out there the longest of the new variants. And we have seen a little bit of the variants of India, the variants of Brazil, but in very low numbers. But what I'm worried about is in other countries that are struggling, if we don't reach out to these countries and we don't help them, what's going to happen is that more variants are going to evolve, and eventually one of those variants could get beyond the vaccine. So some variants, like the South Africa variant and the Brazil variant, monoclonal antibody doesn't work as well. Even dual monoclonal antibody for some of the patients, and the FDA has now not recommended single monoclonal antibody for patients with certain variants. So in time, if we don't help out other nations that are really struggling with infrastructure and vaccine availability, we're going to see new variants arise, and then we're going to be struggling with that as well.
It's interesting that you mentioned that, and I suppose it took us this long to get to the point where we're starting to talk about this. But it's interesting, I was listening to a podcast recently, and they talked about this very thing, and they were suggesting that now is the time for the United States to do something, and they drew the analogy to World War II. World War II, you know, much of Europe and Asia was destroyed. The United States afterwards went in with people and with capital and rebuilt those countries. And it turned out to be good for the United States and good for the world. And the suggestion on this podcast is, why aren't we talking about sending people to all these countries to help them out now that we're stable? It'd be good for the world, it'd be good for our country. So hopefully that's going to get more airtime, and perhaps we'll be headed that way at some point, but I haven't heard much about that.
Well, I think it will, because now we have a seat again at the World Health Organization's table.
Yeah.
So now Biden has put us back in touch with the World Health Organization to support it as well. And I think we'll be embedded in some of those international alliances. And I think that's going to be very important.
Yeah.
If we don't take care of the world and we have an isolation perspective that we've had for centuries, I think that that could make it more difficult on the backside.
Yeah. All right, well, thank you. That's all we have today. I hope you're enjoying this beautiful weather. I will give you one tip. My wife and I did a nice hike last weekend called Islands in the Sky, just off of Duncan Mills. Lovely hike, beautiful views. It's a bit of a hike up, but 2 thumbs up. Give that a try if you haven't done it. But enjoy. Thanks for your time.